whoever make the slides, or we can just go in here.
No, whatever the slides.
Yeah.
Start. Okay, thank you. Good morning, everyone. I'm Chen from Changhua Christian Hospital, and it's a pleasure to be here today to present this challenging case: local regionally advanced squamous cell carcinoma of synchronous esophagus and head and neck with distant oligometastasis. This is a 56-year-old man who is a hepatitis B carrier with a history of gout. He also has a significant history of alcohol consumption, bitonal chewing, and smoking. He initially experienced dysphagia for 1 year, which progressively worsened over the past 3 months. During this period, he also suffered from significant weight loss of 12 kilograms, further raising concerns for malignancy. He initially visited the gastroenterology outpatient department, where an upper gastrointestinal endoscopy was performed, revealing a lesion highly suspicious for advanced esophageal cancer, located at 31 to 40 centimeters from the incisors, and the pathology confirmed moderately differentiated squamous cell carcinoma. To evaluate the extent of the tumor, a chest CT scan was performed. The CT revealed a lobulated mass with significant wall thickening involving the middle to lower thoracic esophagus, resulting in near-complete obstruction and invasion into the bronchus. Additionally, enlarged lymph nodes were noted in the mediastinal and perigastric lesions, highly suggestive of lymphadenopathies. Furthermore, distant metastasis was identified involving the paraspinal soft tissue at T7 vertebral level here. Therefore, the tumor was staged as clinically T4N2M1. As part of the staging workup for esophageal cancer, we performed a whole-body PET scan, which accidentally detected another primary of right tonsillar malignancy over here. To further assess the oropharyngeal lesion, a head and neck MRI was performed, revealing enhancing lesions in right tonsil, cluster lymphadenopathies in right neck, and involvement of the skull base. Here. Stages clinical T1 and 3B M1, and biopsy of the right tonsil proved to be moderately differentiated squamous carcinoma, P16 negative. In summary, this 56-year-old man was diagnosed with synchronous squamous cell carcinoma of esophagus and right tonsil. The esophageal cancer was staged as T4 and 2 M1, while the right tonsil cancer was staged as T1 and 3B M1, with paraspinal soft tissue and skull base metastasis. His performance status was ECOG 1. Lab tests show mild anemia and slightly elevated liver enzymes. Tumor markers revealed elevated squamous cell carcinoma antigen levels. Additionally, the patient is a hepatitis B carrier with low viral activity, requiring antiviral drugs to prevent viral reactivation during treatment. Overall, treatment planning requires a careful balance between systemic therapy, local disease management, and potential risk, aiming to effectively control the disease while preserving quality of life. So this is our treatment strategy. Given the local regionally advanced and distant oligometastasis nature of both cancers, a multi-model treatment strategy was implemented to optimize tumor control. First, we started with first-line chemotherapy using the weekly CD flame regimen. This is a multi-agent combination designed to maximize tumor cytotoxicity while maintaining tolerability. C stands for cisplatin, 60 mg per square meter. D stands for docetaxel, 50 mg per square meter. FL stands for 5-FU combined with leucovorin at 2,500 and 250 mg per square meter respectively. And EM stands for epirubicin and methotrexate, both at 30 mg per square meter. In addition to the chemotherapy, we also include weekly cetuximab as targeted therapy to enhance the treatment efficacy. After 3 months of systemic therapy, you can see a follow-up PET scan down here demonstrate a metabolic complete response of both cancers. Therefore, the patient proceed with consolidation radiotherapy. Gross tumor volume and clinical target volume were delineated based on post-chemotherapy contrast CT scans. The first phase of radiation therapy was focused on the right tonsil cancer, with 66 grade in 33 fractions, administered concurrently with a reduced dose of weekly CD flame regimen here. The second phase of radiotherapy focused on esophageal cancer, with 50.4 grade in 28 fractions. However, due to increased fatigue after prolonged intravenous chemotherapy, oral tegafur-uracil, a prodrug of 5-FU, was used concurrently. Both metastatic lesions were also delineated for better local tumor control in the RT plane. And this is our radiotherapy plane. We compare our RT plane with the pre-chemotherapy images. We can see the irradiated GTP volumes were reduced for 37.3% for right tonsil cancer and reduced for 81.1% for the esophageal cancer respectively. Due to the reduced volume of the radiation, the patient tolerated the whole RT course very well, without interruption. Following radiation therapy, maintenance treatment with oral tegafur-uracil was prescribed at 3 capsules per day. Subsequently, low dose of cyclophosphamide, 50 mg daily, was introduced, with a planned duration of 2 years to further extend disease control. And following our intense treatment, the follow-up CT scan, you can see a complete response. The primary esophageal cancer, as well as paratracheal and perigastric lymph nodes and paraspinal soft tissue metastasis, all demonstrated significant regression. Additionally, a follow-up upper gastrointestinal endoscopy performed 5 months after the first-line systemic therapy showed a complete response, with pathology confirming the absence of viable tumor. For the right tonsil cancer, the follow-up head and neck MRI also showed a complete response, with no enhancing tumor detected. In summary, this is a complex case of synchronous double cancer. Through multimodality treatment, the patient was able to undergo the entire treatment course without interruption. The patient is now still on oral chemotherapy for maintenance, and he is now alive without recurrence for 2 years. And thank you for your attention.
So you can, yeah, we want to face you guys. So, can you see here? Okay. Oh yeah. Okay. Yeah, great presentation. Quick question. So the metastatic, I wasn't clear. Was the metastatic disease consolidated as well? It looks like there was a
Yes.
thoracic spine, right? So that was included in the plan.
Yes.
In the thoracic plan.
Yes.
Okay.
The skull-based plan was incorporated with the right tonsil plan, and the T7 level paraspinal lesion was same as the esophageal plan.
Okay, with the same dose.
Yes.
Okay. And also, did you actually provide nutritional support beforehand, and before starting the chemotherapy, because the patient has this pretty large
Yes.
mid-esophageal tumor?
He had 12 12 kilograms of weight loss before treatment, but during our induction chemotherapy, I think the tumor regressed very well, so he can eat by oral.
Okay, so you didn't need to actually have nutritional support. Yeah, yeah. I think that's a good. Yeah, typically I think of course chemotherapy itself is palliation, pretty adequate palliation for the most part. So yeah, we have considered, of course, in patient who starts with that kind of occlusive tumor, if we're going to do radiation in the front, we typically will have. We don't do prophylaxis for all patients, but particularly in patients who started with upfront radiation, we would actually consider some prophylactic, feeding tube, especially for because during radiation sometimes they actually have worsening of their dysphagia, so we would actually put some prophylaxis. But I guess if you start systemic therapy, yeah, I think that's the case where you can potentially just use systemic therapy up front with that. Yeah, no, it's a good outcome for this patient.
Yes.
Actually. Yeah, it's one of those atypical cases where oligometastatic disease can do very well, and including in these type of cases where even co-synchronous diseases. But I don't know. You guys did this in sequence, which is a good plan. I'm wondering about was the tumor? I couldn't tell from the imaging. Was the tumor above the bronchus or actually below the carina? It seems to be around the area of the carina.
Below Where is mine? 可以放我 PPT 吗？这里，我可以先看吗？给我第几页就好。哦 ，Here.
So it was a mid-esophagus,
yeah,
right?
mid to low.
But I was just wondering in terms of the upper extent, it does not. So it's right below the carina. So it's
Yes,
right,
yes.
Okay. Yeah. So of course, I think if you have considered in patients who has at the level of carina or above, we typically would do a bronchoscopy because you said there was actually some invasion.
Yes, we do bronchoscopy as well.
Okay. Yeah. So maybe for the audience, any MDs here in the audience? Just wondering. Or residents? Okay, I guess not. But of course, I think in settings of, especially with squamous cell, in patients who present with locally advanced disease like this, we always want to do a bronchoscopy because there's a chance for fistulous formation. That means that there's invasion into the carina. And in these cases, you want to make sure that they don't have a fistula or invasion through the carina before you start treatment, because that can leave a hole, of course, at the end of treatment, and you want to be able to know that ahead of time, right? So I think that's the only caveat. But in this case, I think it's below, so it probably might be okay to get away with that. Yeah.